Welcome back, guys, to another episode of the Medical Minute.
I'm Dr. Rick.
And I'm Dr. Danny.
We're excited today to talk about Theranostics, which is a fancy word, but...
Don't get ahead of yourself, Rick. I have a dad joke to say.
Do we have to?
Yes. You're going to love this one. What do you call two monkeys that share an Amazon account?
You got me.
Primates.
Boom.
Boom.
All right.
I got a little bit of a chuckle there.
Yes, respectable. That's a respectable joke.
That's a good one.
Respectable. So, we're going to talk about Theranostics today, which is a fancy word.
It sounds very fancy.
Fancy.
I think you know a lot about this, Rick.
I can speak to it a little bit. That's for sure.
We've been using more of it lately.
Yeah, I think so. And I guess I've become the unofficial spokesperson / clinician taking part
in
charge of this. I guess
don't even know that I'd call it unofficial. I
think
you are
officially.
Maybe
it's pretty official.
Maybe I'll just start making myself feel cooler than I am and just start saying I'm the director of clinical theranostic program at Cancer Specialists of North Florida.
Can you please put it on your white coat?
I will. You know what?
I can change it on the website. No one will know.
If I wore a white coat, I would, but I don't wear a white coat, as my patients can attest to. But yeah, change it on the website because I just want to have that title now. I feel like, why not?
I think you would wear your white coat if it said it on the white coat.
No, I wouldn't.
Okay.
No.
I would. I don't want to be.
You already wear your white coat, though.
I do. Yeah, true.
So we've talked a lot about different ways to treat cancer before, but I think this is probably the first time we're going to delve into this side of things. It's a relatively emerging field. It's not a new field. It's been around for decades in terms of what it is and how it treats cancer, but the success and the different drugs that are currently in development and currently in practice are evolving at a very rapid rate. I would, obviously I'm a little biased and believe in it, but I do think that this potentially could be something that has the impact on cancer care, maybe not quite to the degree, but something that may really change how a lot of cancers are managed, similar to kind of the advancements on your side, Danny, with immunotherapy and some of the other drugs that have revolutionized some diseases. So I think it's worth hearing about, and we have a pretty robust program here at Cancer Specialists of North Florida, bigger than I would certainly have ever believed in a community setting. And honestly, we're doing things that a lot of bigger and more tertiary centers don't do, which is kind of wild.
Yeah, I think it's kind of precision medicine, and we're looking at proteins which are expressed on cancer cells and try to utilize them by first obtaining imaging of patients, and that's usually doing PET scans, PET CT scans to evaluate whether their tumors express certain proteins that we can target with treatment.
Yeah, yes, and also there's kind of different categories of them, but the basic concept is you link a radiation producing particle to a protein that is specific for a cancer cell, as Danny was alluding to. And so the way the treatment works is, in theory, this molecule will go around your body, and anywhere it sees this protein on a cancer cell, it will deposit radiation. There are different radiation delivery products, if you will, in terms of how the radiation is delivered, different emitters. Probably won't get into the weeds of it here, but there's alpha emitters, beta emitters, gamma emitters, different ways the radiation is delivered that has to do with how much radiation, how far does that radiation go, that sort of thing. But the basic concept is these radiation producing particles are linked to a cancer-specific protein, and anywhere that protein is, that tumor or that area would receive the radiation. Some are cancer-specific, as you were alluding to, more precision medicine like PSMA, and lutathione, which we'll get into, but some of the more original ones were not quite as cancer specific, like Xofigo for prostate cancer, which is radium that actually targets the component of cancer in the bone specifically. It's not looking at prostate cancer specifically, but bone cancer. So it's a little less specific, but still relatively specific to prostate cancer in the bones. But these newer agents treat not only cancer we see in the bones, but also in other parts of the body. So a little more specific.
Yeah. You can imagine, the challenge of, any targeted or precision medicine is to find a target which is specific for the cancer and is not highly expressed elsewhere where there's normal healthy tissue, because you don't want a high dose of radiation and you don't want a chemotherapy. We don't give chemotherapy with these agents, but we're trying to avoid excess toxicity, which could affect patients' quality of life and outcomes. So I think the newer advancements in the Lutathera and PSMA have really and are still evolving and going to probably change standard algorithms of how we treat these diseases. So Rick, can you tell us a little bit about your experience? Let's start with Xofigo being kind of that not so precision, therapy that we offer to prostate cancer patients. We give it for patients with prostate cancer, which is affecting their bone and metastasized to the bone. Could you tell the audience about how that's administered and what to expect from a treatment like that?
Yeah, so the nice thing about Xofigo and a lot of these agents we'll talk about is, in general, the short-term side effects tend to be very minimal. In general, it's much more well tolerated than your standard cytotoxic chemotherapy. Usually don't need much support in terms of medications. But basically, the way Xofigo is given is actually very easily over a 1-minute infusion given through a peripheral IV once a month for 6 doses. So it's very not time consuming for the patient. They're in and out of the office in 15 to 20 minutes. They receive their dose and they go home. The main side effects we watch for with Xofigo, but also all of these agents, is bone marrow toxicity, because the radiation is being deposited in the bones where the cancer is, and there is going to be some damage to the normal marrow. And as you know, Danny, in a lot of these patients, by the time they're coming to me, sometimes they've already seen other chemotherapies or other agents that have already kind of potentially repressed the bone marrow production, so they're certainly already at higher risk for complications, and certainly these agents don't help them in that regard. But even still, most of the bone marrow toxicity is transient, meaning that their counts may drop, but typically will recover on their own. But that is definitely what we watch for the most, and as Danny could tell you, we work in close contact with our medical oncology colleagues should we think they need any growth factors or other things to help boost those counts back up. But thankfully for most patients, they don't need support like that, and it's more of something we tell them their counts are down on their blood work, but they don't really feel any different day to day.
Yeah, usually, the appropriate patient for Xofigo is a patient who is not severely anemic, because we can see anemia develop sometimes with Xofigo, and usually is not to the point where we have to hold therapy, but we're looking for a patient who has a pretty normal functioning bone marrow. And these patients, a lot of time, like Rick said, have been through a number of treatments, and we're using this to kind of delay progression and hopefully yield some kind of pain relief as well.
Right. So I think, the main indications for Xofigo and kind of where the data shows it provides a survival benefit is in patients whose disease is bone only or predominantly in the bone,
right,
and who are also having, as you mentioned, pain. Xofigo certainly can help in that regard. Now, if you have a prostate cancer patient with a bunch of disease in the abdomen or the pelvis, then Xofigo is probably not the right treatment for them, because it's not going to address that disease. It's really going to only focus in on the bone parts of their cancer. So it's patient selections, of course, like anything, very critical.
And to stay in the same kind of topic here with prostate cancer, we have a new theranostic or a treatment that we're offering here at CSNF, both in clinical trial setting, and I think in the near future we might have FDA approval where we can give it outside a clinical trial setting. PSMA, which is prostate-specific membrane antigen, and this is specific for prostate cancer cells. And Rick, can you tell us a little bit about the background of this new technology and how it's helping patients?
Yeah, so I think it's been known for some time that most prostate cancers express PSMA on their cell surface. So the cancer cells have this antigen on the surface of their cell that has been, a hypothesized target that drugs could use to be specific for prostate cancer. And this PSMA is essentially there's two components to it. One is a scan portion, a diagnostic PET scan portion. So we've all probably, and we've talked about on previous episodes, a standard PET scan uses radioactive sugar, but these PET scans actually use a radioactive PSMA. So anywhere there's cancer cells that express PSMA, that scan will light up. So what that scan tells us is, do your cancer cells express this antigen?
Mm-hmm.
And if the answer is yes, those patients may potentially benefit from the treatment. The treatment is the same PSMA molecule, but instead of being linked to a radio tracer for imaging or diagnosis, it's linked to a radiation emitting particle, which in the case of most PSMA at this time is a beta emitting particle called lutetium, which is, like I said, kind of double speaking, but it emits beta radiation to kill cancer cells. The way that's given is similar to Xofigo in that it's an infusion through an IV. It's typically given over about 5 to 6 minutes, and it's given every 6 weeks for 6 total doses is the standard there. So that day is a little bit longer than a Xofigo day because you get a little bit of fluids with it. So patients are in the office for about an hour or two, and then they go home. But it's only every 6 weeks, so it's not too much of a time commitment for the patients.
Mm-hmm.
Similar to Xofigo, the main side effect is the bone marrow blood count side effects. So we keep a very, very close eye on that, as well as their pancreatic function, because there is some risk of pancreatitis with this medicine. Those are the two things we keep a very close eye on. But because this is specific for the prostate cancer cells, I would say most patients tend to seem to tolerate it with minimal short-term side effects from it. To your point, Danny, and kind of to toot our practice's horn, so there's two settings in which we use PSMA. Mm-hmm. One is in the advanced setting, so in prostate cancer patients who've already been diagnosed with metastatic prostate cancer, who've failed other therapies. So they've failed chemo, they may have failed advanced androgen deprivation therapies, they may have even failed a second line, chemotherapy. Those patients, there's now phase 3 data that's been published showing a survival benefit. So patients will live longer if they get this lutetium PSMA. Mm-hmm. That drug in that setting is currently under FDA review as we record this in the end of February. I know it's going to take away a little bit of the magic when you listen to this in March, but as we record this at the end of February, it's not FDA approved. Right. But here at Cancer Specialists of North Florida, we've worked with Novartis to open an expanded access program. So patients in that situation can come to us, and we can still deliver this PSMA lutetium on basically a clinical trial. So it's not a clinical trial testing one side or the other. Yeah. It's for Novartis to help monitor safety effects and efficacy going forward. So that's one category we have open.
And we're the only site in Jacksonville doing that, Rick?
So we are the only site in Northeast Florida with that expanded access program open.
Right.
And even more, I would say, I get some of this credit, but really I don't deserve it. A lot of it goes to our research team and Mary Alice and her crew, and Jessica Vicari, who we've had on this program, and Mary Alice we've had on this program before.
Shout out to both of them. Thank you. We
are actually one of the only sites in the country with the PSMA addition trial open. So this is upfront, newly diagnosed metastatic prostate cancer. So patients who have not had chemotherapy, they have not had other therapies. And this study is actually a 50-50 randomization to standard of care. Mm-hmm. Get 50% of the patients get standard of care. The other 50% get standard of care plus this PSMA drug. So we are fortunate to be one of the only sites in the country with it open, and we're doing that in a community setting, which is pretty cool. So patients, we've already had patients traveling from all across the country to come here to see if they're eligible for the trial. And certainly I would encourage you, if you have family, friends, whoever with prostate cancer who want to learn more, even if it's just to reach out to find out what that information is, we certainly can provide that for you. But it's a pretty cool, feel very fortunate to be a part of it, that we can do this in a community practice and really give it to the people who sometimes don't have access to clinical trials, who can't, maybe they can't afford to, or maybe they can't travel to, the big expensive centers across the country. So I think it's a kind of a neat thing we've done.
Right. And this is the studies taking place here at South Point, right, at our
so
AC Skinner location.
Correct. We can enroll you at any of our clinics, but the way that the protocol, at least at this moment, we're working on expanding it. So hopefully in the future we'll be able to do it at our other clinics. But as of now, they would travel to our South Point office at AC Skinner for the infusions. But again, it's every 6 weeks. It's not a daily thing,
Right.
like typical quote unquote radiation we've talked about. So,
And they can get their standard of care therapy probably at the office
So,
where they see their oncologist.
yes and no. It depends
Yeah.
on the situation. But
Okay.
again, even with the standard of care therapy, in most cases, you're taking a pill
Right.
and you're getting a shot every so often. So
Right.
even still, the burden is not, it's certainly not weekly. And usually it's, a couple times a month you'd have to travel at the most.
Okay. Well, even the imaging technology to have a new imaging modality that, and not everyone, but in some patients is very useful because their cancers express this PSMA, and it can be really a guide for how good your treatment's doing and whether you're getting significant reduction in the tumor.
Yeah, I think, and we've hit on this on other episodes, but
Yeah.
I don't know if it'll be interesting to see where the data goes with
Mhm.
PSMA PET. I think it's certainly, it's more information, which is good because it
Mhm.
helps inform decision making, and we'll learn sort of, will we get to the point where we can use that to maybe determine treatment intensity or, adding or removing different agents in certain settings. So it'll be interesting to see where that diagnostic pathway leads us. But right now, I think it's very helpful because it can probably more accurately stage patients than
Yeah.
conventional imaging.
I think prostate cancer is one of the tough disease states with imaging because you have a lot of different imaging modalities you can do. You can do plain CT, diagnostic CTs with technician bone scans. You can do an FDG PET scan, although a lot of the time it may not show up, bright in the areas where you're hoping to see it. But I have had patients with, subsets of prostate cancer, which are maybe, neuroendocrine differentiated or something where FDG PET does have some role in utility in looking at where their disease is. And then we have the flucyclovine PET that, is the Axumin PET. So now we have PSMA. So just another thing on top of it, which we've got to really hone in and figure out what's the best imaging modality for what patient.
Yeah, and I think the nice thing is at least there's a lot of open trials studying this question, both in not just metastatic but localized prostate cancer patients, and trying to.
Yeah.
I think in the next 5 to 10 years we'll really have probably a better handle on when to use it, who's it appropriate for, and how should it be used to influence treatment decisions.
Right.
But no, I think, so prostate cancer is obviously the big one because it's the most common non-skin cancer diagnosed in men. The other program we have open here at CSNF is Lutathera lutetium with dotatate, and that's to treat neuroendocrine tumors, which is not as common as prostate cancer. But once patients fail frontline therapy with neuroendocrine tumors, which thankfully, in this disease, many patients live many, many years, even decades with their cancer. But eventually, as you can speak to better than I can, most patients will at some point fail their octreotide or their frontline therapy. And in that situation, Lutathera provides a very, very nice second-line option that has been proven to increase survival in a randomized trial. And like with the prostate cancer, lutetium thankfully has a very low risk of acute side effects. So patients aren't sick or miserable during the treatment, but it's the same thing as, sound like a broken record, we're really watching their blood counts and bone marrow because, again, that tends to be the main side effects with these agents is transiently lowering their myelosuppression.
Yeah, and I think the second, third line treatments we have for neuroendocrine tumors tend to have a variety of toxicities. If you're treating with higher intensity chemo or you're using mTOR inhibitors, they all have downsides compared to the new Lutathera treatment. So
it's nice to save that maybe for later on if you can.
Yeah, or until something better comes
out.
Right.
Well, that's what I tell these and it's funny. I've had many neuroendocrine patients come to me and say, 5 years ago, this Lutathera was a pipe dream,
Mm-hmm.
and now it's in practice. But they live long enough where they can actually, if you can keep them going,
Right.
and their quality of life is good, and they're not feeling anything, then, like you said, they may be able to live long enough to see that next advancement, which is very cool.
I mean, these are generally very slow-growing tumors, but they can be metastatic to a variety of places in the body and can be locally a problem depending on where it's growing. And Lutathera, I think, leads to some regression of the tumors and a longer treatment-free interval, kind of. You're delaying progression.
Right, and I think that's important, a very important point. None of these, like most systemic agents, we're not talking about a high likelihood of getting rid of all the cancer cells or
Right.
curing you of your cancer, but it's life prolonging.
Mm-hmm.
And the nice thing about this is it's life prolonging with, in not all cases, but most cases, a very minimal detriment to the quality of life. So I
Right.
think it's a good trade-off for a lot of patients.
Now, with all this radiation to the bone and elsewhere, Rick, do we have to worry about leukemia or blood cancers with these agents?
So you definitely do. Just like with chemotherapy and other systemic agents, there's always a risk of a secondary malignancy with these agents. That risk, thankfully, is low.
Mhm.
Looking at the trial, you're talking somewhere between less than 1% to about 3%,
Right.
and that includes MDS or myelodysplastic syndrome. So not
Mhm.
necessarily leukemias always, but sometimes just complete suppression of the bone marrow.
Right.
So if that happens, of course, it's a very serious and unfortunate complication. But thankfully, that seems to not be it's a very, very rare complication to
Right.
the therapy.
And I think education is important because we're treating cancers in these settings which are not curable cancers. We're trying to extend their life expectancy as much as we can to hopefully get on to better therapies in the future. We certainly don't wish any of these hematologic side effects on anyone, but when it comes down to quality of life and having intervals where you're not on treatment, I think that's why we opt for these new therapies, even with these small risks of serious side effects.
Yeah, I think, and I say this to patients when I'm talking about anything. I say there's always a risk.
Yeah,
Surgery,
sure.
radiation,
Right.
standard radiation versus radiopharmaceuticals versus chemo versus immuno. There's no such thing, unfortunately, as a free lunch,
Mhm.
meaning there's always going to be a risk of side effects with any of your treatments. And, none of us
100%.
can make a decision for a patient on what they want to do. I view our job as you lay out the pros and cons and ultimately let the patient decide. I mean, we can give recommendations, but it's ultimately their decision. Because I could sit here and tell you a side effect's very rare, but if you're the person with that side effect, you don't really care how rare
Right.
it is because you have it. So it's definitely, you have to be very mindful of that. I think one of the other things, just very briefly, is this is the beginning of a wave of agents coming. They're already testing in breast cancer, similar molecular targets with lutetium. We already have, and we have here at CSNF, the ability to do PET scans, breast cancer specific PET scans for estrogen receptor expressing tumors. So that is something I think in the next 5 to 10 years, we're going to see an explosion of these radionucleotides, both on the diagnostic side and on the therapeutic side.
Yeah. And I think overall these therapies have less toxicity than chemotherapy overall. If you look at the side effect profile, patients don't feel as sick on them. And then you have a defined treatment duration,
Mhm.
Where you're on treatment for every 4 weeks for 6 doses, every 6 weeks for 6 doses. So I think compared to the agents where you have all these oral agents out there, and a lot of them are very good, but you have to remain on them for it to be effective. So you're on it pretty much indefinitely until it doesn't work. So I think it's nice to have the opportunity to have some of these new agents where it's a defined period of time you're on treatment.
Well, thank you guys so much for coming back and listening to another episode of Cancer Specialist Medical Minute.
If you have any suggestions on things we should talk about, questions you'd like answered, or just want to say hi, you can email us at medicalminute@csnf.us.
And make sure you follow us on social media. Search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram.
And as always, we appreciate you giving us a few minutes of your time and hope you learned something today. I know I did, Rick.
I think you did.
Thank you.
And remember, when it comes to your health, stay informed
Ask questions
and tune in next time.